Yep.
Yes. Yep. Okay. Well, thank you. So you can move to the next one. So I was hoping through the next 10-15 minutes to provide you with how the Champlain Complex Care program came around. What are the objectives of the program, a bit of a summary of the model and the team, what evaluation framework system that we've used, share with you some of the successes that we've been able to evaluate, and as well as some of the challenges, and then we'll be open to a discussion afterwards. So you can go to the next one. So this initiative actually started as a pilot project in 2008. It was our family forum that had identified that there were significant deficiencies in our system to help and care for some of the children. And at that onset, brought forward together around the same table community agencies, including CCAC, which is our community nursing agency, our outpatient treatment center, the rehab program, as well as our hospital, and another group called the Coordinated Access, who offers more guidance and support for mental health. And the common deficiencies or challenges within the system, which are frequently highlighted, included that the existing system was not patient or family focused. The organizations were frequently working in silos, that there was a global impression that these complex, medically fragile, technology-dependent children were orphaned to the system, and that there was absence of mechanism to share information across the system, which frequently resulted in fragmented care, frequent and prolonged hospitalization, at times unnecessary hospitalizations, increased risk for medical errors and duplication of services, and also parental stress and burnout. What really drove this initiative to move forward in our area was our family. So if you continue. So over the course of 1 year, we did a scan. There was a small group that was identified, and we did a scan of the environment and tried to identify how we would bring forward an initiative and a pilot program. So we first identified program objective, which, as here indicate, we wanted a family-centered approach. We wanted to facilitate communication and collaboration amongst all care providers. We wanted to coordinate the child, youth, and their family and all their needs across the whole system, including their home, the community, and the hospital. Wanted to relieve the burden of that care coordination from the families, and we wanted also to, by the same token, improve their overall satisfaction with the service, as well as reduce duplication of services, and then in the end, as a result, to improve their health status, because they would be less in the emergency department. We would hopefully reduce their lengths of stay in hospital, or even avoid hospitalization, and hopefully improve the overall family's health. Next slide. So these break slides are comments from our families. We've done yearly surveys, so this is a comment from one of our family. Next slide. So the model. So when we first started, we, in red, wanted to highlight how we would bring together a team for the family. So whenever we had a child identified or a youth, we would determine who would be the most responsible physician, which is the MRP. For the time of the pilot project, the MRP was actually assigned with the pilot project, so we had only one RP at the time, and that was me. Then we wanted to identify a coordinator or uh, um, a team member from each of the agencies where the child was receiving care. We also identified other physicians within the hospital that were important into the care of the child. For example, if you had a child that needed respiratory support, we had a respirology as part of the team. And all of the care providers that were required are part of this child's team. We did an initial assessment of the child from a medical point of view. We would then sit with the family and determine what we call a medical roadmap. So those would be all of the care need, the test, the investigation that would be required over the next year course. And then we also would align with the family who were the team members they felt should be part of the team. About a month or two within the recruitment within the program, we would have what we call a family-focused team, and we would bring around the table all care providers determined by the family and our community agencies in the hospital that felt that needed to sit down and then did sort of a troubleshooting session in determining what were the main issues that needed to be addressed and produced and identified what were the care issues or care plans to support the child across the system. Next slide. Oh yes, so this represents over the years. So we started this officially in March of 2009. And over the years, we've determined that the MRP did not have to be within the hospital, so we expanded the role of the MRPs to the community as well. Next click. Over the years, we've also expanded our partnership and have added to our team other agencies such as a palliative care team, the CYMCS. We've talked as well at times about bringing on board the school, which we have done depending on the different child situation. Next. We also had hoped to bring an electrical health record system where everybody could connect and get the information. It is in our hospital and community in development, but we're not quite there. It's been all along identified as a limiting factor. But in the meantime, we have put together a summary document that the family and the agencies determine who they want this document to go to, and we try to update this document every 6 to 12 months depending on the child's needs and the child's health, and we make sure that the information is at different time interval. The information is sent to all the required team members. Next slide. So this is a different configuration of all the agencies and group that are involved in the care of these children, but in principle it consists of MRP. So first I'll say the CCAC is our community nursing agency. The OCTC is our outpatient treatment center. And both of these agencies will have case managers, will have social worker, occupational therapist, dietitian, and other allied healthcare provider. And we also have the CHIO, the hospital, who we also have other team member, and all together we would determine who would be the individual, such as if we need a social worker, we would determine, okay, which agency, who's going to be the social worker, so we do not use the social worker of each of the different agencies. As an example. So you can see that in CCAC there were identified 6 family coordinators there were 6 children of our program that were with coordinators from the CCACs. There were 14 that were with coordinators from our coordinator here at the hospital, and there was 1 that was with the OCTC. The next slide. So we've received funding, and the funding is primarily to support the nurse coordinator's role in our hospital, because that was not a role that was existing before. We now have 2 nurse coordinators. It's also to provide support for a data coordinator, as well as a program team manager. And then we have the MRPs. We have 2 that are full-time connected to CHIO. We have several community pediatricians, 5 and at times 6 pediatricians that are committed to this population with the complex care program. And we also have in-kind services with CCEC and OCTC. And this, over the year, the role of each of these team members has been realigned and redefined as well, because over time, our patients change, but also the agency's roles and funding changes as well, and they have had to review some of their role definition in connection with the complex care. Next slide. So as the years evolved, this is somewhat what we've developed as a vision. And we hope to be able to achieve this care delivery model where it's defined as a level 1, 2 to 3. And each of the level is further defined by the care needs of the child, by who would be the best care provider location, and what kind of system navigation the child or youth requires. And the purpose of this is because we want to expand the program. We want to assure that there is a flow through, and we want to use the resources appropriately over time. We also want to make sure that there's an ability to expand the number of children that we can service within our community. So a level 1 would represent a child that has frequent use of the hospital. Frequently, a common term that is used is frequent flyer of the hospital system, either using the emergency and or the hospital for hospitalization and or the ICU. And that setup, the care provider, the MRP, will be most likely hospital-based with the nurse coordinator from the hospital, primarily to facilitate that medical care coordination piece in addition to the community. Having said that, all along, for each of those children, we do want a connection with the community primary care provider, and also an assigned worker from each of the different agencies. And then in principle, we determine where all the care coordination required. It's also the hospital and in the school, in the home, and then we assure that we have all the right connection within the community to assure that coordination. A level 2 is a child that requires, and youth that requires less the hospital, but still does require it, but at a lesser intensity, but still is considered complex, fragile, may or may not be technology dependent. And in this case, the community, the MRP may be the hospital or the community, and the coordinator will primarily be a hospital-based, just to assure the connection with all the specialists in the hospital and the connection with the community. And then the level 3 would be a child that is rarely using the hospital in terms of the emergency and hospitalization, but still requires that care coordination and that connection with the hospital because of the specialists involved. And in this case, the MRP would be more a community MRP, and the coordinator would be also within the community. Next slide. So the service delivery model is based on individualized care need. The objectives when these patients come into the program is to provide individual care plans, medical roadmap. It's to assure there's appropriate use of the different services in the hospital and community, and to assure good care coordination. And to assure that, we've developed inclusion-exclusion criteria, screening tools. Whenever there's a patient that's referred to the program, we have a discussion with the referring physician, and we also have a discussion with the community care provider. And when they're already connected to other agencies, we also have communication with them prior enrolling a patient. And as they're being enrolled, we produce a single point of care document, which is a full summary of the medical condition, brief history of the summary of the child with medication, all the specialists, the care provider in hospital and community, and also we identify the technologies and the important testing or evaluations that were done of the child. Next. And again, next. So this is to highlight that the population that we're identifying is the peak of that pyramid. These are the children that are most complex, fragile, and frequently technology dependent. There has been an evaluation of how many of these children there would be in our local community through an Ontario initiative, and we estimate there would be about 100 plus or minus 10, 20 children that would fit those criteria of our program. So we currently have 25 children on the program, and we have now moved on to a program phase, and we are at a referral phase. And so we estimate that this year, with 2 full-time pediatricians, we're going to expand the program to about 40, 45 patients. Next slide. So next slide, you may have seen in the recent article published in Peds and Health. This is a parent of one of our children that has used a similar slide to determine what are all the care need of her child related to her condition. And I think this is worth 1,000 words into all of the different areas that this mother needs to coordinate and connect and communicate with at different point in time. And it's a tremendous endeavors to, we frequently forget what are all the pieces and the issues for these children and these families that they need to manage. Next slide. So when we started this pilot project, we wanted to make sure we had a process of evaluation, and we used the principles of program evaluation and developed an evaluation framework that focused on 5 main domains, including implementation, accessibility, acceptability, healthy utilization and resource, and the health status. So for implementation, we were looking, are the activity of the pilot projects that were intended, are they truly being practiced? And is the implementation truly occurring? For the accessibility, we wanted to make sure that we were reaching out to the right children and youth and the family. Acceptability, we wanted to get feedback from the families as well as from all the healthcare provider, whether or not this was achieving what it was meant to be. And then health utilization, we were taking up data, looking at hospital days, pre and post the intervention, as well number of emergency and various area of use of the system, including our community physician as well as our CCAC respite hours. And next slide. And then to further break down the program evaluation, for each of the domain, we've identified indicators as well as the data source of where we would get the information, the method of collection of the data, and then what we would compare it to and how we would evaluate that data. Next slide. So for the 1 year evaluation, and when I talk about 1 year, it's spanned over about 3-year period. It's a 1 year of data from the child being recruited to a 1 year after for 19 children. And they were not recruited all at the same time, but they were recruited between March 2009 to March 2010. So that 1 year fell after the 2010. So if we look at those 19 children for whom we were able to use all data, the median number of conditions was 10, from a minimum of 7 to up to 17 conditions. The median number of teams involved in the care of these patients was 11. 94% of the children that were in the pilot project did require specialized medical equipment, and they were all considered medically fragile based to our definition. So we felt that we were meeting the group that we were targeting for. Next slide. So with over 1 year period, when we look at the service utilization 12 months before the recruitment and 12 months after their recruitment, we identified that there was a statistically significant decrease in number of hospital days from 20 to 7. We also identified that there was a statistically significant increase in outpatient clinic, and there was a statistically significant increase in the CCAC respite hour. Next slide. So this slide, as a graphic, shows that the total number of days went from 524 to 250 for the 19 patients in the group, and we had one of our economists do a case costing. So if you pressed on the next again, and again, and then one more time. So when we do a weight cost per patient days in the hospital, these number of days that were saved represent almost $750,000 of saving in the number of hospital days. And these were children that were randomly selected, and I can expand on how we did this, but these children were already within the system being cared for and receiving all the required services. So these are not children that were hand-picked. It was really a randomized, selected number of children. Next slide. For the emergency, there was a decrease in the number of visits to the emergency, and there was a trend down. However, this was not statistically significant and did not have the same kind of financial impact. And you can keep clicking on the number until you see the box on the side. However, what I want to mention is that those are the children that when they present to your emergency, they frequently will be stuck in the emergency for quite a number of hours, and they are challenging, and they are times are difficult to assess efficiently into an emergency department. So if we are able to reduce the number of these visits to the emergency, it does help in the system to improve the efficiency of the system, not just for the emergency, but also to address the issues of the child differently at a different level within the system that is helping the overall efficiency of the system. Next slide. We've asked our family to provide us some feedback, and we've sent them a family satisfaction survey at the 3 different years. So the overall response rate, the first 2 years was just a little bit over 50% and a little bit less on the 3rd year. But overall, the rating has been mostly satisfied to very satisfied for the coordination and for the quality of the service. Next one. I will try to move up. So we've asked, this is just to highlight what the positive feedback families had, and the bigger the words, these were the more common themes. So this is from the families, what they felt. Yeah, the one call, focus, effective coordination, less visit to the hospital were positive feedback from families. Next slide. So one of the father from the project wrote us that at one time or another, he wrote us what this program represented to his family and gave us this feedback, which I think speaks well of what this program does. At one time or another, all 3 members of our family have suffered from anxiety, depression, and severe lack of sleep. Once we were taken under the wing of the coordination of care team, we felt our stress instantly removed. Suddenly, the committee of people caring for our son had a chairperson, and the ship was finally sailing in a straight line. And a roadmap was created, and we have a plan to follow and only one person to call. So the single point of phone call is very commonly a positive feedback and a relief for families. Someone is accountable to make sure things are coordinated, and as a result, our contact with the hospital and our use of the hospital resources is greatly reduced. So most importantly, we can put our son to bed knowing that everything that should be done is being done. If something should happen, we have access to the resource. Next slide. And next slide. So there are certainly lots of challenges as well. I mean, one of the main one is it's been extremely challenging to move this from a project to a sustainable program. So since September, this is officially a program. However, I still do not have the assurance that this is going to be a sustainable program. And the main reason for this is identifying funding on a yearly basis. While this is happening, it is a dilemma to enroll patients when the future is uncertain, and also to recruit so many different individuals within the system to participate in the care of these patients. Retaining team members has also been a challenge over the last 4 years. Maintaining dedicated in-kind services also is a challenge. Agencies, hospitals, roles, funding, you always have a review of who does what, how they provide the care, and that sometimes can impact how, as a team, we can all work when we are trying to be integrated within our community and trying to cross all of the different systems and the silos. Next slide. The key factors for the success was the single point of care, and the coordinator is one of the key most important role. The tools certainly have been a success, in particular the summary document, having a medical roadmap, and also we've got a lot of feedback from the family and the ability to bring around the same table so many different groups, agencies, or care providers at the family focus team meeting. We do not have access to care 24/7, but that is ultimately the goal. Another key factor is providing the continuity, because these children are complex, and it's important to know what does occur over time and build trust and relationship with these families. Collaboration with all partners is essential, because we wouldn't be able to provide that care program in our community without their collaboration from everybody. And then to have a group of MRPs, not only in the hospital, but in the community as well, and work collaboratively all together. Next slide. This is a slide for me. It's just to create an analogy in that that rowboat wouldn't be able to move straight unless you have collaboration from each of the individual, and it has to be well coordinated to make it move forward. So next slide. I just wanted to acknowledge that this is the work of many, many different individuals coming from each of the different agencies working with us in partnership for this program initiative. So I'm done. If we can move to questions.
Great, thanks, Natalie. So does anyone have any questions for Natalie?
I want to say an
outstanding
I
just have one.
Great presentation, Natalie. Go ahead, Tammy.
Mm-hmm. Oh, sorry. Yes, thanks so much, Natalie. That's so interesting to hear what you guys are doing. One of the roles that we don't have in BC is this coordinator role, and I know some of them are kind of based in your clinic, nursing coordinators, and then there are community people as well. Would you just give me a couple words about what their specific function is, and are they a nursing background or are they a different background?
Yes. So the coordinators from our OCTC, the Outpatient Treatment Center, are actually social workers. The coordinators from our nursing agencies are usually nursing. The coordinators within our hospital are primarily nurses. And some centers will have nurse practitioner. Other centers will have advanced care, advanced nursing. I think it depends where the level of care of the child is in terms of their care needs. So if there are high users of the system, the nurse role, they provide, if there's an urgent call, they will help to facilitate where they should be seen. And they'll be able to do a medical evaluation of the agency of that phone call. They also will connect with the specialists, making sure they can align the follow-ups and the medical roadmaps, so sort of determining what frequency of blood work at what interval should be done. in our community, they don't have that role. However, they can connect with the coordinator here in the hospital to support them in defining those determinants. So, so the coordinator in the community will be able to facilitate more of the services for the school and for the home. And when our children require those services as well, our hospital coordinator will communicate with the community coordinator to help and facilitate that. I don't know
Thank
if
you,
there's
Natalie.
Okay.
It's Marley Robertson speaking. I wondered, does the most responsible physicians here, do they do follow-up clinics? Do they have physical space, or are they there as consultants for the nurse care coordinators?
So they do. So for the hospital MRPs, we do have a clinic. We do provide urgent care in a clinic in the medical day unit. So if there is urgencies, we determine that the nurse will contact us and will determine where they should be seen. We also will provide follow-up at different time interval around every 3 to 6 months. And as the child needs less and less of that care need with the hospital, we then transition and we alternate. So one visit is with the community primary care, the next visit is with the MRP from the hospital, and then reevaluate at 6 to 12 month interval and determine if the child should be then discharged to the community MRP.
Just one other question. If there's not 24/7 access to the care coordinators, what do families do out of hours?
So if there's an emergency out of hours or even during hours, they come through the emergency.
Thank you.
Now the emergency has access to the medical summary, the SPOC team, the SPOC document that we have provided. So that has been feedback we've received from the emergency has helped them because they don't have to go through, 20-something volume to get all the required information to get an idea of who's this child. And also the family reports that they feel they don't have to repeat their stories over and over because they can refer them to that specific document.
Natalie, this is Lisa. I'm just wondering, that single point of care document, is it updated like every 6 months, or
yes, so
change?
Yeah, so it's individualized. We try to make sure at least once a year, but it all depends. Some of these children, they have changes almost every 3 months. We will update them every 3 months, and it is the role of the coordinator to assure that those documents are updated.
Great.
Natalie, it's Gemma Vomero from Calgary. I have a question about the roadmap, and just wondering who is responsible for determining the roadmap up front, because I would imagine that will be very unique for each patient. So is that the MRP that does that?
Yes, so we develop it at the beginning during the intake process, and I send it off to all the specialists and as well as to the community physician. So, we've had 2 documents now sent to the community pediatrician, and we shared with them that we feel that will become their responsibility to update this document. So that becomes the role of the MRP.
Okay.
Yep.
It's Marley Robertson. Do any of the families just feel that this is just one more clinic in that they already have 7, clinics that follow them up, or are they all perceiving that the benefits of this clinic with the burden of yet one more trip to the hospital?
Good question. So I have to say at the beginning, many of these families came with a lot of anticipation and worries about having yet another specialist, another group, and another clinic. However, as time moves forward and they see the accessibility to a one-point person and helping them out to figure out many of what they felt they had to do as work, as phone calls, or accessing results, or accessing to make sure that a test is done at the same timeline of another test because one specialist required something, or even to find out, you know, there's a new medication they've received, they're wondering if there's a drug interaction. Over time, people so far seem to identify the benefit. However, as time goes, when some of these children become don't need as much of the hospital, they're happy to be discharged back to the community and not to have to come back for yet another extra appointment, especially when they're told they're doing much better.
Okay,